Good afternoon, everyone. I'm really delighted and honored to get to welcome all of you to our panel. My name is Dave Choksi. I'm a primary care doctor. I'm the former health commissioner of New York City, and currently I get to chair something called the Common Health Coalition, which you'll hear a little bit more about. It's really a privilege to have a chance to moderate this session, which I can assure you will be brilliant, even by the standards of Aspen Ideas, mostly because of the brilliant panelists that we have as a part of this conversation. So allow me to briefly introduce each of them to you. First, we have Dean Megan Ranney, who serves as the Dean of the Yale School of Public Health. To her left is Dr. J. Nadine Gracia, who's the president and CEO of Trust for America's Health. We have another president and CEO, Dr. Brendan Carr, who joins us from the Mount Sinai Health System. And to his left is Admiral Rachel Levine, who serves as the Assistant Secretary for Health at the U.S. Department of Health and Human Services. So welcome, and thank you so much for joining me. Each of you has a really unique vantage point on public health and healthcare, but let me try to get the ball rolling by saying a little bit more about the Common Health Coalition. The coalition was founded last year with the fundamental mission of strengthening partnership between healthcare and public health. This mission is personal to me, as I know it is to our panelists, and I suspect it is to so many of you in our audience as well, in part because during COVID-19, I saw what a reimagined health system could look like, one that worked seamlessly across public health and healthcare simply on behalf of the people that we serve. During the pandemic, we saw silos dissolved. For example, there's simply no way that we would have been able to pull off the largest vaccination campaign in New York City's history and our nation's history without hospitals, doctors and pharmacies, health plans, and public health, among others, working in unison. But as attention to the pandemic has ebbed, so too have some of those partnerships. And we're at risk, I would argue, of snapping back to business as usual, instead of capitalizing on that momentum that we saw. The Common Health Coalition really is just about refusing to accept that as a static reality, and instead choosing action over amnesia and turning memory into a movement. So, I'm gonna next just share a short video. This is just a 1-minute video to say a little bit more about the Common Health Coalition, if we can play that now.
You might not know. Healthcare and public health are two critical pieces of America's health system that, believe it or not, haven't always worked consistently together. But during the height of the COVID-19 pandemic, saving lives meant having to work hand in hand. In many places across the country, the arbitrary walls that kept the two fields divided disappeared seemingly overnight. This unified, de-siloed health system should be our new normal. Instead, we are seeing the opposite. Walls are being rebuilt and life-saving innovations left behind. There is a future in which those hard-learned lessons from the pandemic aren't forgotten, but instead are identified, amplified, and replicated across the country. That's why we created the Common Health Coalition. 5 leading American healthcare organizations have banded together under one banner for the first time with a clear purpose: to pursue a reimagined health system, one in which public health and healthcare work hand in hand to save lives and prevent suffering. A common goal, an uncommon approach. Join us at commonhealthcoalition.org.
First, I'm really grateful to the founding organizations of the coalition. As you heard, the AMA, AHA, AHIP, Kaiser Permanente, and ACHP, which is the Alliance for Community Health Plans. I want to give a shout out to the CEO of ACHP, Cece Connolly, who's here. Thank you so much for joining us. And as you heard at the end, we are seeking to grow the coalition, and so I'm really pleased to make a very special Aspen Ideas announcement in that vein, which is that nearly 50 organizations have signed on to the coalition, When we talk about that uncommon approach, it's because this is not just about issuing recommendations. People join the coalition by making a specific commitment to partnership. That includes the organizations that are led by each of our esteemed panelists here, and we're adding more each day. So if our mission resonates with you, please do visit commonhealthcoalition.org and please consider joining this movement. Okay, thanks for allowing me that soapbox. So now on to our main event. And I want to start by asking each of the panelists briefly to respond to the same question. The title of our panel this afternoon is From Measles to Maternal Health, Why Stronger Partnerships Between Healthcare and Public Health Matter. So let's rest on that question of why just for a moment, because each of you has, through your leadership and your work, bridged the realms of healthcare and public health. So maybe each of you can share a bit personally on your own why or how you found yourself at that intersection. And Megan, maybe you can start us off.
So how I came to this, I'm originally an emergency physician by training, as well as a public health researcher, and honored now to be Dean of the School of Public Health. But part of the way in which I came into this is because as an emergency physician, I took care of folks day after day who walked through the doors of my emergency department with an acute physical or mental health complaint that was caused by the situations in which they lived, worked, and played. I diagnosed it, I tried to provide treatment, and then I sent them back out into the same conditions that had brought them to my doors in the first place. As a healthcare provider, as well as a public health professional, I know how much money we are spending on healthcare already, and yet we are seeing life expectancy drop in the United States, never mind seeing health span, healthy life, drop in the United States. And I got tired of seeing that disconnect between the structural drivers of health that we know are so important to helping to create a healthy population and the healthcare part of health, which is only about 20% of someone's health. And to me, this connection is about making it easier for doctors, nurses, social workers, physical therapists to do the jobs that we were trained to do, to care for people as we want to care for them, while not requiring us to take on all of the public health functions that need to exist in order for the healthcare system to do well. That's really what drove me into the work that I do now. Most of my work is actually around violence prevention, particularly gun violence prevention on a personal level, but also to my decision to become Dean of the School of Public Health in order to help bridge that gap, to create connections of data, of resources, of community empowerment that make all of our jobs easier, but most of all make the lives of the communities in which we live better.
Thank you, Megan.
Sure.
Nadine.
Thanks, Dave, and I echo, and I'm checking, mic check, yes? All right, I echo the appreciation, Dave, and the Common Health Coalition for pulling together this panel discussion for all of you attending here. What drives me really is a passion around health equity, and I come to that both from a personal and professional background. My family is originally from Haiti. I'm the first generation born in the U.S. I know the opportunity and the investment that has been made in me to be sitting in this chair. And yet, when I was growing up, I also saw the disparate opportunities that far too many people I knew that they didn't have to be able to really pursue opportunity, but also to be healthy. I trained as well as a physician. I became a pediatrician, and remember actually during my training, I would often get teased because I would spend so much time on the social history that they would, whenever there was a complex issue, they'd actually bring me in to do the social history, just that alone, to be able to diagnose what was happening. But in that social history, I learned so much about how we needed to address many of the things that Megan just alluded to. Going back into communities and into environments where you didn't have access, for example, to healthy and affordable and nutritious foods, or you lived in a home that wasn't safe, wasn't healthy, especially for patients that we were caring for with asthma who had environmental exposures in their communities that triggered their asthma. And I just realized that there was truly an opportunity to both be able to care for the patient and also address the broader system and conditions and really try to create healthy community conditions so that everyone could thrive. I transitioned from clinical practice to policy and went to Washington, D.C. specifically to work in policy, and I've seen the strengths that both sectors have. And I understand that bringing those sectors together, we can leverage those strengths truly to promote health and well-being for every person and community, and that we can work to end health disparities in this country and around the world. And so my passion is, how do we give everyone the opportunity to be as healthy as possible?
Thank you. Brendan.
Thank you, sir. So I too, emergency doc, pediatrician, we're sitting every other, yeah, just so I don't get confused.
There's a theme.
Yeah, so I too am an emergency physician, and as Megan said, that is the place where all failed social policy ends up, in the middle of the night, and so it's a great lens into what's working, what's not working in healthcare policy. And that's a piece of the story for me of the reason for the focus at healthcare and public health. The other piece is I spent the first decade or so of my career really studying trauma systems, studying what happens when you are not part of the decision around what happens to you when you wreck your car on a lonely road in the middle of the night. Decisions get made for you, and the infrastructure to create a safe pathway to high quality care is a reflection of this private sector system called healthcare and sort of this public entity called EMS and public health and infrastructure. That was part of the story. I went to the federal government to work to run the emergency care policy office at HHS, and all of our levers and all of our connections were to state health departments. And state health departments, most of them anyway, don't run healthcare systems. They think really differently. They're public sector entities funded in a public sector kind of way. They don't understand insurance reimbursement and sort of just-in-time efficiency pathways, all the things that make the healthcare system, candidly, disincentivized to make sure that there is a ready home should things break out, like for, say, a high-consequence infectious disease that happened a couple years ago. So, my portfolio in government really was about figuring out what that bridge looked like. I worked with the VA and the DoD to think about, what if something happens? At the time, by the way, it was North Korea. I don't know if you remember how the high tensions with North Korea. What happens if all of a sudden there are military casualties or there are expats that need to come back to the US and they need a healthcare system? There is not really an incentive to bring those people into the healthcare system. We barely, sometimes, make budget, break even, when we're at 105% capacity. And if you've been to an emergency department recently, have probably noticed that we're over capacity. And so for me, this partnership to understand how we can make the roles clear, but the relationships really seamless, is critical, because we're all depending upon it.
Thank you very much, and I'm pleased to be here. I'm also one of the pediatricians in pediatrics and adolescent medicine. I trained at actually Mount Sinai.
Thank you very much.
And have been in academic medicine for many years, both at Mount Sinai and then at Penn State in pediatrics and adolescent medicine. So saw our healthcare systems up front, providing care to children, teenagers, and young adults. And then I have been in public health in states. So I had the opportunity to be the physician general and then the Secretary of Health of Pennsylvania. And then the world changed in 2020, and I helped lead Pennsylvania through the first year of the pandemic. And then got a fateful text one night, would you be interested in a position in the Biden administration? And went, well, yeah. And here I am as the Assistant Secretary for Health. So I've seen actually all of those systems and know that it is absolutely critical for public health at the community, at the state level, and at the federal level, and international level to work together and to work with health systems. The example that I would like to bring up is in terms of the overdose crisis. So one of the first issues when I came to Pennsylvania was that we were trying to address the opioid crisis and the overdose crisis. And I had the opportunity at that time to not know what I didn't know. And I said, well, as a state health official, could I write a standing order prescription for the state for naloxone? And at first people went, well, no, you couldn't do that. But I pushed, and eventually, after being vetted by 475 attorneys, they said, yes, you can do that. And so that involved, community health, and involved health systems, the state, involved the federal government, because we worked with HHS and ONDCP a lot, but it also involved health systems and emergency departments that you were talking about, trying to address the opioid crisis in terms of prevention, trying to make sure we prescribe opioids carefully and judiciously. In terms of harm reduction, particularly with the medicine, the overdose reversal medicine, naloxone, and treatment, trying to get more and more prescriptions for medication for opioid use disorder, particularly buprenorphine. Spoke with many, many emergency medicine physicians about being able to even prescribe buprenorphine in the emergency department after they've seen patients that have come, and then recovery. And so all of that involves that interplay between all of those different systems to deal with an enormous health crisis that persists today.
Wow, what a rich set of experiences we have to draw upon for this conversation. And I will observe they put the internist here separated from the pediatricians and ER docs, lest I pontificate too much about differential diagnoses. But what I hear in each of your answers is such a strong and compelling case, almost to the point where it feels so common sense that we should be doing this. And in a way it is, but before we kind of delve into the how of, how we can advance progress with respect to this partnership, I do want to rest a little bit on the communication of the problem in the first place and how we should really think about this as a kitchen table conversation, as it were, because the most common response that I get from folks who are not sort of steeped in the world of health, when they hear that, I'm working on this coalition to strengthen partnership between healthcare and public health, is like, no duh, why aren't you guys doing that already? Why does it take a coalition to bridge those silos? But that is the truth, as you've all alluded to, that that something like this is necessary. But it does present a communications issue, right? When some people, particularly the people that we're serving, everyday folks, sort of don't recognize this as a problem in the first place, what is our task to communicate about it so that we do have, some broad-based consensus that things need to change? So I'd like to invite, maybe one or two of you to comment, but maybe I'll pass the ball to Megan, because this is something we've talked about, and as you know, I think you're such a superlative communicator.
Yeah. Thank you. No pressure. Jeez. I mean, so I think part of it is that folks honestly don't even know what public health is. I mean, let's be honest. Everyone knows what healthcare is because we've all set foot in a doctor's office or a nurse practitioner's office or in an ER at some point in our lives. But most of us have never thought about how we intersect with the public health system and how it's government public health. But great public health is actually much, much more than government public health. So I think the first part is just explaining why a functioning public health system matters. And then the second part around the communication challenge becomes making it clear to folks how this collaboration makes a difference and where some of the barriers currently exist. And Admiral Levine, you mentioned opioid overdoses, and people are shocked to learn how much work it has taken to share real-time data between hospitals and public health systems around where opioid overdoses are happening so that we can then go and target those hotspots and pass out naloxone or have peer recovery specialists in place, right? People don't even understand that data sharing is not happening. The other part around the communication, and I'm sure we'll get to this later, is the communication also to our next generation. If I look at my students at our School of Public Health at Yale, or if I look at our med students at Yale School of Medicine, there are not a lot of places in which they intersect, and this is despite being at a school that is well known, thanks to Howie Foreman, for its great intersections between medicine and public health. So I think we're not even talking about it at that student level, so we're training generations of practitioners that haven't thought in the same language or how to talk to each other. I think the last part is telling the stories about how the intersection helps to keep us all healthier. And to me, one of the spaces where I love to tell stories is about that seamless handoff between healthcare and public health, and then vice versa. When we have powerful structures and systems in our communities, in our society, that have gardens, that have access to healthy food, that have access to healthy housing, that get people air conditioning during a heat wave, that means that I have fewer people coming into my emergency department, but it also means that when I take care of them, I can send them back out to somewhere that helps to keep them healthy. And those individual level stories make such a difference when we think about communication.
I'm glad you're surfacing, some of the examples which we're going to delve into a little bit further. But before I do that, let me just invite any of the other panelists to comment on, how do we communicate about this as a kitchen table issue?
Well, I think communication, as you were saying, is absolutely critically important, and we certainly saw that during the acute phase of the COVID-19 pandemic. But I'm going to draw to the title that you talk about it was you mentioned measles, and of course we're pediatricians, and so the tack that I would like to take is communications about vaccinations, about immunizations and vaccinations, and the challenges that we have with that, and the challenges we have with misinformation and overt disinformation about childhood vaccines as well as adolescent and adult vaccines. Immunizations are one of the victories of public health in the 20th and 21st century in terms of conquering smallpox, in terms of getting close to conquering polio, although we're not quite there yet. But even other infections that you and I know, Haemophilus influenza type B, Hib disease, which caused so many infections when I was back at Mount Sinai in the 80s, that we would see children with meningitis, with sepsis, with pneumonia, osteomyelitis, and you don't see Hib disease because it's a safe and effective vaccine. And so we are having those challenges. There were no cases of measles in the United States in the year 2000, and now we do see cases of measles and other childhood illnesses, other vaccine-preventable illnesses, because we don't have the immunization rates. Now, we're still doing pretty well, and better than actually some other countries, but we need to continue to do better in terms of our immunization rates. But there are those that, for their own purposes, are talking, again, misinformation and overt disinformation. And so it is incumbent upon the collaboration between public health but also healthcare, which provides most of those immunizations, to be able to work together to get our kids immunized against diseases that we can prevent.
Nadine and Brendan, well, first, Brendan, did you want to chime in on the communication question first?
The measles question, actually, if that,
Please,
is that
go
right?
ahead.
It's just interesting to think about what it means to not have a disease that is on your differential ever, then be on your differential. Because what it means very clearly is that you miss it because you're not thinking about it. And so there are cases across the city of New York. There are the communication strategies to the public and even to the providers about the degree to which we should be on the lookout are lost in all the news. This is, it's a needle in a haystack. But one of these kids comes to one of our hospitals. If they're not isolated right away, often they're too young to be masked. They contaminate everyone around them in the waiting room, in the rooms adjacent to them, the nurses and doctors that walk in. It is crippling, in the ripple that it causes. So yes, 100% the vaccination, but yes, the communication piece, right? I mean, the idea that somehow we're going to make everyone aware that this disease that you don't know is lurking is unimaginably difficult, unavoidable.
Yeah, measles is such an important example and one that we talk about because it has to do with the way in which seamless healthcare and public health collaboration, when done right, is all about speed in ways that we have seen our response, particularly in the United States, trip up, whether it's COVID-19 or H5N1. But for measles, it's so clear because the most commonly accepted definition of a measles outbreak is 3 linked cases. But just think about that for a second. How do you know when you have 3 cases and whether they are linked to be able to activate the machinery of the public health response to contain the outbreak, before it gets bigger? And that has to do with the nitty-gritty of how data is transferred between healthcare and public health. We'll talk about data a little bit more, but Nadine, I wanted to pick up on one of the things that Megan had said about workforce. And this is kind of a tall order, right? Because on the public health side, we have a beleaguered workforce, in the wake of the pandemic. And, one of the most common conversations in healthcare is about burnout as well. And so what is our response to people who say, this is like one more thing that we are asking of folks who have shouldered so much over the last few years? How should we respond to that?
Well, I'm glad you've raised the issue of the workforce, because the workforce is so vital to just not only promoting the health and well-being of communities and the nation, but protecting. And we've been talking about this through the lens of infectious diseases, and so many people will often say that you don't know what public health is or what it's doing because it's often invisible, and that when public health is doing its job really well, you don't know it because it's invisible to what society is seeing, what communities are engaged in. And yet public health is not only addressing these infectious disease outbreaks. Public health is also addressing maternal and child health. It's addressing food safety. It's addressing our environment in terms of air and water quality. Each and every day, it is protecting the public's health. And so sometimes you could flip the dialogue to say, what outbreak didn't happen because of the actions of public health in coordination with healthcare? What types of interventions are being put into place around a non-infectious disease that is actually helping to promote and protect the health of communities? But what we know is that the system, speaking specifically of governmental public health, has been underfunded, chronically underfunded for decades, and that underfunding has also translated in terms of the workforce. There is a severe workforce shortage that predated the pandemic. The Great Recession of 2008, significant job losses in public health departments. It's continued through the pandemic, and yet we need that workforce to truly be able to be there to provide a core part of our infrastructure in promoting health and well-being. And it's time, if not the COVID-19 pandemic, that we need to think of public health infrastructure, including the workforce, as a part of our national infrastructure, as part of our national health and economic security, because it has work each and every day to provide that security. And yes, the workforce is fatigued, there's burnout, there's also harassment of the workforce in a way that, is certainly in recent years with the pandemic. The level of harassment of local health workers really has been troubling. And there's also the challenge of not having adequate funding to even hire the workforce and then continue to train the workforce. We're seeing programs, we're talking about the number of threats that we face. Infectious disease, we haven't yet spoken about bioterrorism, various attacks that can happen, and yet the funding for emergency programs in which we'd actually build that workforce has actually declined over the past 2 decades. How can we decline in funding for the very response that we need to have and train that workforce? The other thing is the competition as well with outside of the government sector in terms of the pay and not being able to compete against other sectors in terms of being able to maintain that workforce. Those are the various things that are challenges. But what we also know is that this is a committed and dedicated workforce that works through every challenge, works through every threat, and is so committed to protecting and promoting health and collaboration with healthcare. That's in the DNA of public health. And so I think we can really seize on this opportunity, as has been stated, the way in which either relationships that already existed in communities that were strong between healthcare and public health were basically enhanced during the pandemic to be able to surge in capacity and provide the need and support for the communities that were being served, or new partnerships and relationships that were being created. We can't allow those to now dissipate because the community still needs that integrated system. And so I think you have a dedicated workforce, but you also have a workforce that has truly been under attack and really needs support, not only from public health leaders, but certainly from leaders in other sectors as well.
Nadine's organization, Trust for America's Health, put out a really good report examining some of these issues with the most salient title. It's called Ready or Not. And so if you want to learn a little bit more about that, I encourage you to check that out. But let me try to get us even more concrete about partnership and what does that look like, feel like? Where are the places where it's happening, where we can identify, amplify, and replicate across the nation? And Rachel, I wanted to ask you to maybe start with this. I mean, you get to see so much of this because you travel the country. And then I know even though H5N1 is very much sort of dominating the headlines, it's another infectious disease, syphilis, that your office has been spearheading our response to. So maybe you can say a bit about that.
Well, thank you. I wanted the opportunity to talk about really a crisis of syphilis. This is another disease which in the year 2000 we virtually didn't see in the United States and had a significant decrease globally, but has been increasing globally and in the United States over the last 8 or more years, and that has accelerated over the last 3 years during the COVID-19 pandemic. Many young physicians have not seen syphilis. They have not read about the diagnosis and the challenges of diagnosing syphilis, and then the rather sometimes complicated treatment depending upon the stage of syphilis. But we have seen a significant increase in primary and secondary syphilis, and then a resulting increase in congenital syphilis. And as a pediatrician, adolescent specialist, I have seen all of it, actually at Mount Sinai during my training. And
it happens other places too.
I'll take your word for that. I've seen primary and secondary syphilis. I have administered that large shot of Bicil in LA, and tragically have seen congenital syphilis in the NICU. And we saw 2,700 cases of congenital syphilis in the United States in 2022, which is the latest CDC data. So we have started a task force on syphilis, primary and secondary syphilis, and congenital syphilis. It involves all of the different divisions at HHS, including, of course, the CDC, FDA, NIH, HRSA, and Indian Health Service, ARC, and more. We also have the VA and the DoD at the table. And we're working on the data and the surveillance, which we have great work from the CDC on. But we're also working in terms of prevention, diagnosis, and screening. Syphilis had really fallen off the routine screenings for STIs because of it was infrequent. Well, it's frequent now. And we very much appreciate the American College of OBGYN recommending screening for syphilis 3 times during pregnancy, at the diagnosis of pregnancy at 28 weeks, and then after delivery. And then having that being uptake by healthcare systems across the country. And then making sure that emergency departments are testing for syphilis, that urgent care centers and more are testing for syphilis. And then using a new point of care, a new rapid syphilis test. And we just put out a point of care syphilis testing considerations document from the task force. It's a new test over the last 2 years. It has its advantages and disadvantages, but it's uniquely, I think, the right test at the right time, because you can have a diagnosis in 15 minutes. Now, there are limitations to that, and I don't want to get into the complexities of it, but I think it offers a lot of possibilities. And then making sure that we treat for syphilis in the face of a shortage of long-acting Bicillin, a shortage of Bicillin in LA. They are made in the United States by Pfizer. We are working very closely with Pfizer and appreciate they're very much leaning in on increasing production. I'm going to have the opportunity to visit their plant in Michigan later in the summer. And they are really responding to the challenge of the syphilis challenge that we have in the United States. But there's a new treatment paradigm from the CDC called DoxyPEP. Doxy post-exposure prophylaxis, which offers a tremendous amount of opportunity for syphilis and other sexually transmitted infections. Well, all of this involves a close collaboration with federal public health, with state public health, and we're leaning in on 14 jurisdictions with the highest rates of syphilis, but then also hospitals and health systems and healthcare, both in terms of emergency departments, in terms of STI clinics, in terms of syringe service programs, and in terms of making sure that all of our trainees know how to diagnose syphilis and know how to treat it. So we are committed under the Secretary Becerra's leadership to really addressing this and trying to stop the spread of syphilis and to bend the curve, and then to start to see decreases in primary and secondary syphilis, and then in congenital syphilis.
And just resting on this example for a moment with you, Rachel, are there cities or states that are really exemplars in being able to forge partnership across healthcare and
Yes.
public health to respond?
So California is one. California has really done a really good job leaning in on this problem. We're working with their state health department. They are one of the states that have the highest rates of syphilis, and we're working really closely with California's health department. But we have really great collaborations with all of the health departments that of those most hard-hit states, as well as the District of Columbia, and then all other state health departments. So we're working really collaboratively with them. And another example actually is the Navajo Nation. Very high rates of syphilis in American Indian Alaska Native communities. And the Navajo Nation has done some really innovative work with these rapid tests and then actually treating syphilis at people's homes. Testing and treating people in these homes. I was recently there a month or more ago, and I mean, it can take 3 hours for someone to get from someone's home to a treatment center, and so people aren't doing that, and so they're sending community health workers right to people's homes in the Navajo Nation, testing them and getting them treated so that we can nip this disease in the bud.
Thank you. Brendan, I wanted to turn to you because one of the coalition's priorities, as you know, is what we think of as always-on emergency preparedness. The idea that preparedness is something that best happens in peacetime, so that we are not scrambling to put together plans in a time of crisis. And really importantly, to make sure that they are not siloed plans, so that each health system and the public health department have different emergency preparedness plans, but rather that everyone is reading off of the same sheet of music. This is something that you've worked on, for your entire career, and then I know that Mount Sinai recently launched a Center for Healthcare Readiness. So I wonder if you could say a little bit more about what needs to happen nationally.
Thanks. I'm never the one who doesn't say national health security on the panel first. So thank you, Nadine, for saying that for me. I think when we think about how this all connects, and the conversation about syphilis is a great one, because what does it require once you see it, in a clinical setting? People have to be tracked. You got to find their partners. That exists somewhere. Data's got to be transferred. People have to be treated. We have to then know whether or not we're talking about a single case or the measles case. When is it 3? You have to have data structures that work. And I know we're going to get to it in a little bit, but if I take out the word syphilis or measles and I put in biological attack, right? All of a sudden, it's the exact same infrastructure, the exact same muscle memory that we would use to make sure that we are able to communicate effectively. You heard Dave say that it's all about speed so that we can start to isolate, understand what's happening, and mount a response. So at the end of the day, most of the things that we think about in the national security space have a health consequence, and yet this entity called Public Health and Healthcare are not often at the table when there's a conversation in the national health security space. So that's piece one. And then piece two is the regulatory mechanisms for healthcare. There's the distributed ownership of getting that message from CDC, from the state health department, from all these partners that are working that have content expertise. How does that get to healthcare? How does it get to the provider? Well, it goes from the state health department. There's an announcement. It comes to the providers. We sort of hope that the providers are reading the announcements, but it's the best way is for us to hardwire it into their practice by putting it into the electronic medical record or by creating something that makes it sort of foolproof, a reporting system that's running in the background so that the moment the diagnosis is made in the laboratory, it's being fed somewhere. Those things don't happen organically, and we struggle because the regulatory side of healthcare comes through departments of health. There isn't really don't get mad. There's not really a federal entity that fully owns this on the readiness side. Mm-hmm. Readiness is distributed across a couple different entities because is it Homeland Security? Is it CDC? If it's sort of public health and then it becomes readiness, it feels like CDC. Is it the Assistant Secretary for Preparedness and Response? Does it exist in the new Office of White House Pandemic Preparedness? And then when you ask about how you convince a health system to do it, we all say, well, CMS has some regs that will use the payment models to make you be ready. The fact that it's everywhere means that there's not really an owner. There's not a single convener saying, here's the 15 different things that we're going to do to make sure that it's always on, right? And so that convening power, there are parallels for that convening power. I'll spend 20 seconds on this and just sort of say, we're a private sector enterprise, but we deliver something that most people consider to be a very, very, very sort of public sector right. That's a tough dance. That happens other places, the banking systems. we expect that they're not going to go down when bad things happen. They have. We've done a lot to make sure that they don't. The electrical grid, we expect that the lights are going to stay on because there's a relationship. There's the federal entity that says, here are the rules of engagement, and then there is this private sector entity that says, we will comply by those. We don't have that for readiness in healthcare, and it would be a foundational structural change. But Yale is building one.
Yeah. Maybe with Sinai, but
there you go.
I was just going to go. You mentioned this in passing, and I just wanted to go deeper into the thing that you said around trust. And so part of emergency preparedness is the trust of the community that you are going to be there for them, and that also is built in peacetime. And so when I think about emergency preparedness, it's about having that relationship with the community, that they know that we are listening and that we have their best interests at heart, and we are going to respond to their needs today, so that when the emergencies happen, the communication out is trusted, and there are already trusted partners out there who can take that message and disseminate it. So not just healthcare providers where we have systems built to send out you need to screen for syphilis now, but also barbershops, pastors, daycare owners, superintendents of schools, and I could go on, who are ready and linked and believe us, whether in healthcare or public health, know that what we have said in the past, we have kept our word on, and that we have a path for sharing communication with them. And I answered your question before about communication in terms of this public health healthcare combo, but communication is also about making sure that folks feel agency and know how to take action in these moments of crisis. And to me, that's so much of emergency preparedness, which I know that you have spent a lot of your time on as well, but I just want to really highlight that as part of when we think about that next step.
Thank you. We're approaching the end of our time. Based on the clock that I have in front of me, because the sun is shining directly on it, we either have 8 minutes or 80 minutes left. So I'm going to assume that it's 8 minutes. So I have just one last question, which I'd like to invite all of you to chime in on, starting with you, Rachel, which is that, as is appropriate, we have spent a fair amount of time cataloging the problems, talking about what needs to work better. At the same time, there are so many people who are already working at this intersection today who give us reason for hope. So I wonder if each of you can share just what springs to mind for you when you think about what gives you hope with respect to this reimagined health system that we aim to build.
Well, thank you. So it's sometimes obvious that I'm a positive and optimistic person. And I'm positive and optimistic because I choose to be positive and optimistic, because I choose to have hope for the future, because I think the alternative is despair and cynicism, and then it makes us less able to do the work to accomplish what we want to accomplish. I think that we are working towards many of those, this collaboration and this coordination that we've been talking about in this session. In preparedness, in infectious diseases, in maternal health, which we didn't spend much time on as well. And I think that health equity is at the foundation of it. And you had talked about health equity, Nadine. And under Secretary Becerra's leadership and really the leadership across HHS, I think that we are making that progress. And I think that we're working closely with hospitals and health systems. I think we're working closely with state and local health departments. And I think it is really just incumbent on us to continue that work and to continue to have hope for the future and then work together to make that happen.
Brendan, what gives you hope?
For me, it's the front line. It's the folks that are doing it, because there's just no question in their mind that they are going to do and they want to do the right thing. And they see the solution in the face of technology. They know that it's going to be stitched together. When I say, call this phone number, it's the dog bite hotline, and you're gonna hit 1, hit 4, hit 6, right? You're gonna wait. It's gonna take 20 minutes, but I'll see the next 3 patients for you. They see a different future. They know it's coming. And someone said that public health's been underinvested in for years. That's a truism. Public health IT systems get to where healthcare IT systems are, and we add AI and magic happens, right? And it is running in the background, and we are getting surveillance tools that tell us at a population level that there's an outbreak, that something's happening.
Thank you. Nadine.
Thank you, Brendan, for saying that point around building the public health data infrastructure,
Yeah.
because just to give as an example, there are still health departments during the pandemic that were manually entering cases and then transferring. Did I see a raised hand? Are you from one?
Yep.
There we go. And transferring that data then to get into these broader systems. It's not efficient. It's more administrative burden for the healthcare system. It's not as fast and real time. What we saw in the pandemic as well, though, was investments through emergency legislation, through the American Rescue Plan Act, to start to build that infrastructure, to modernize that data infrastructure. What we can't do is turn back. And the concern that we have is that our lawmakers at all levels they're diverting their attention to other issues, and we need to actually do exactly what we've all been talking about. Is in order for this collaboration, this partnership, to really reach its full potential, then both of these systems need to have the infrastructure to be able to do so. And we need the voice of others. Certainly, yes, we in public health and healthcare can be advocates in this space, but that will help us to promote health and well-being. And this is not only to just respond to emergencies. This is for the rising chronic diseases that are happening in our nation that are continue to be the leading causes of death. Every day, public health is working on how do we create programs and interventions. There are proven programs and interventions that can address and prevent chronic diseases, but we don't invest in prevention. Our $4.3 trillion annual health spending, less than 5% goes to public health and prevention. We have to change that. What gives me hope is when I travel around the country and I see health departments, I see health systems, and what they're able to do with the resources that they have to be able to meet the needs of communities. What also gives me hope is the workforce that Megan is helping to train and lead at Yale, because they have greater expectations of what we can accomplish in promoting health and advancing health equity for our nation.
Perfect segue.
Well, you took my answer. Which
We know each other a little too well.
But what gives me hope, I'm looking around this room and I see kind of junior healthcare providers, rising star faculty, folks that are still in their training, and they are what give me hope, because you will not tolerate a world in which we don't intersect. You are demanding it, you are creating those coalitions and partnerships already, and that gives me more hope than anything. Brendan and I we were not co-residents, but have known each other basically since residency and beyond, and I think about the discussions that we've had over the years and the way in which it's shaped both of our careers, and knowing all of you that are in the room that are starting to have those conversations at those early points of your careers and thinking about where you're going to be in 20 to 25 years, that gives me tremendous, tremendous hope. I will also say that there are some specific examples that give me hope. Gun violence, for those that came to our session this morning, the work and the coalitions that we are building between public health writ large, not just government, but also community organizations and healthcare systems, and government in general, is truly transformational and is a great example of how we can address a chronic problem, a chronic epidemic, in ways that bring the very best of both systems together for the sake of change. So I'm with Admiral Levine. I am an incorrigible optimist, but I also know that the only way that we get from optimism to actual change is through action. And so again, it is all of you in the room that are the thing that give me the most hope.
Those are such powerful reasons. So first, join me in thanking our panelists. I know we didn't get to audience questions,
Sorry.
but I invite you to come and ask anyone, sort of what's on your mind. And I invite each of you to join us at commonhealthcoalition.org if this feels like something that is right for us to advance right now. Thank you.
Well done.